organization of this wonderful conference and webinar. Thank you for the opportunity to present the result of our research. My name is Alla Egorova. I am the leader of the Samara Cancer Registry in Russian Federation. Using our data, we study trends in malignant neoplasm incidence and today present an epidemiological panel of cancer incidence among women in the Russian Federation. Excuse me. The number of new cancer cases worldwide projected to increase from 14 million to 20 million between 2012 and 2030, becoming the leader cause of morbidity and mortality worldwide. Among the main methods of finding cancer, which included early diagnosis, specialist treatment, survival, quality of life care, and palliative care, primary prevention is highest, primary, and most effective. Socialist knowledge of cancer risk factors in different countries. In different countries could prevent 1/3 to 1/2 of cancer cases. The organization of oncology care in the Russian Federation is the national priority. Since 2009, various cancer control programs have been implemented in the Russian Federation. The largest project of combating malignant neoplasm for 2029-2030. One section of this program is information and communication campaign to develop anti-cancer behavioral stereotype and among the population. The Samara region has a population of 3.2 million, 55% of whom are women. There are 108,000 registered cancer patients. The region has 55 outpatient clinics, 53 oncology offices, 12 outpatient oncology care centers, and 1,900 oncology beds. For scientific justification and improved cancer prevention program for women, we followed were studied the structure of cancer incidence, age-related incidence trends, the structure of absolute increase in morbidity associated with age or risk factors. The study included patients registry in the Samara Cancer Registry database between 2012 and 2022. A total of 170,119 cancer patients were included in the study. The indicators were analyzed for the period 2012-2022. The mean values, confidence intervals and percent increase or decrease were calculated. The component analysis of morbidity was carried out using the methodology of Russian epidemiological Dvorin and Aqsa. The panel of epidemiological trends was developed using our one methodology. As a result, a regional epidemiological plan of female morbidity and complete for the period 2012-2022. This is a brief analysis of morbidity, the reason of its increase, decrease, and recommendation for primary prevention measures for very common, rare, and very rare malignant neoplasms. Let me present the result of our research. After including one melanoma skin cases, 75,170 cases of malignant neoplasm were registered in women. The crude incidence rate increased by 50%. The increase was observed across all age groups. In the structure of absolute growth, the component associated with risk factors exceeded a component associated with negative demographic trends. All malignant neoplasm were divided into 4 groups. Very common occurring bright pink graph, frequently occurring pale pink graph, rarely occurring dark blue graph, very rarely occurring light blue graph. The population of very common malignant neoplasm was 55.2%, frequently occurring 24.2%, rarely occurring 5.8%, very rarely 2.66%. Among very often malignant neoplasm in women were breast cancer, colorectal, endometrial, cervical, stomach, and ovarian cancer. The increase in the incidence of breast cancer is associated with popular aging, the population in the working age groups, and epidemiological risk factors. The increase in the incidence of colorectal cancer is associated only with the aging of population, and the process of the population is working age groups. The reason of increase in the incidence of endometrial cancer are the process of aging and the population of women, as well as risk factors. The increase in the incidence of cervical cancer is associated with epidemiological risk factors. The stomach cancer, the overall incidence trend trend is decreasing, but in women age 59 years, there is an increasing trend. The reason of the incidence of ovarian cancer incidence are related to the population of women age 29 and 39 years. Among often malignant neoplasm in women were lung cancer, thyroid, kidney lymphoma, practical cancer, leukemia, as well as melanoma and brain tumors. The increase in lung cancer incidence is associated with aging, the population process, as well as the impact of risk factors. The increase in thyroid cancer incidence is associated only with the impact of risk factors. The increase in kidney cancer incidence in women is due to aging and the population. The increase in lymphoma incidence is primarily due to the population, aging, and epidemiological risk factors. The increase in pancreas cancer incidence is primarily associated with the population processes, population aging, and significant impact of epidemiological risk factors. Leukemia incidence has shown is a general downward trend, but significant upward trend was being recorded in women age 29. The increase in melanoma incidence in women is associated with both the population and epidemiological risk factors. The increase in brain cancer incidence is associated with aging and the population. Among the rare malignant neoplasm in women were cancer of bladder, oral cavity, liver, vulva, and vagina, as well as malignant neoplasm as soft tissue and gallbladder. The reason in the increase in bladder cancer incidence are the population processes. The increase in the incidence of oral cancer is associated with both the impact of risk factors and processes of the population and aging. The incidence in liver, the increase in liver cancer incidence is due to the increased impact of epidemiological risk factor, aging processes, and the population. The increase in the incidence of vulva and vagina cancer is due to the aging for the female population and the population, especially in the 40-49 group. The increase in the incidence of soft tissue cancer is primarily due to the impact of epidemiological risk factors. The rise of gallbladder cancer incidence is due to the population of the female population. Among the very rare ones were malignant neoplasm as the esophagus, mediastinum, small intestine, lip, eye, bone and joints, and as well as the pharynx, nasal cavity, and larynx. The increase in esophagus cancer incidence is associated not only with aging and the population, but also with the impact of epidemiological risk factors. The overall incidence of mediastinal cancer has decreased. However, an upward trend has been recorded among women aged 30-39. The increase in small intestine cancer incidence is associated with aging the population and increased exposure in epidemiological risk factors. The incidence of lip cancer has decreased. A similar trend has been observed for eye cancer. The increase in bone and joint cancer incidence was associated with aging the population in the 29 and 39 age groups. The increase in pharynx cancer incidence is due to the increased exposure in epidemiological risk factor aging and the population. The overall incidence of nasal and middle eye cancer has decreased, but an upward trend has been recorded in the 30, 39, and 50, 59 age groups. So we have obtained a panel of epidemiological morbidity among women in the Russian Federation. Among the most common malignants, an increase in incidence occurring in breast, colon, endometrial, cervical, and ovarian cancer. The impact of risk factor was noted only in 4th localization. This amounted to 62.4% of all very common malignant neoplasms. This is what a panel looks like for the very common malignant neoplasm. Among common cancers, the impact of risk factor was observed only in lung cancer, thyroid cancer, lymphoma, pancreas cancer, melanoma, and brain cancer, accounting for 59.1% of all common cancers. This is what a panel looks like for common malignant neoplasm. Among rare cancers, an increase in incidence occurred across all cancer sites. Risk factors were observed only in cancer of the oral cavity, liver, and soft tissue, accounting for 50.5% of all rare cancer. This is what a panel for rare malignant neoplasm looks like. And among very rare cancers, an increase occurred in 4 localizations: cancer of the esophagus, small intestine, bonus, and pharynx. The impact of risk factors was noted in cancer of the esophagus, small intestine, and pharynx, according for according for 42.1% of all very rare cancer. In this slide, this is what a panel look like for very rare malignant neoplasm. So our study standardized a primary cancer prevention program for women in the Russian Federation. It showed I am at reducing the impact of risk factor for breast cancer, endometrial, cervical, lung, thyroid, pancreas cancer, lymphoma, skin melanoma, and malignant tumor of oral cavity, liver cancer, soft tissue cancer, esophagus cancer, small intestine cancer, and pharynx cancer. Therefore, the main direction of the programs should be focused on the formation of a healthy lifestyle for women, their balanced diet, the vaccination prophylaxis, biochemical and oncology, and endocrinology prophylaxis. Our study showed that these measures can prevent more than half of malignant neoplasm diagnosed in women in Russian Federation. Thank you for your attention.
My name is Sawsan AlAskari. I am a senior specialist nursing administration working in a health coach clinic. My background about in nursing, I work in Qatif network in primary health center in Saudi Arabia. Today, my topic is the effectiveness of lifestyles health coaching in a primary health care center. This topic focusing on how health coaching can improve people's lifestyles, preventive disease, and support long-term well-being. Let's go outline. My voice is clear?
Yes, clear.
Okay. Introduction, core principle, key focusing area, coaching process, role and competencies of health coach, challenge and consideration. So what is the exactly lifestyles health coaching? Lifestyle health coaching is a client-centered, evidence-based approach that empowers individuals to adapt last behavior change in an area like nutrition, exercise, stress, sleep, and substance use, using tools from behavioral science, motivational interview, and lifestyle medicine. Health coaches work collaboratively with the client to set personalized goals, identify the barrier, and build self-efficacy. Unlike prescribed models, coaching emphasizes to self-discovery autonomy and mobilizing internal strength and external resource. Let's talk about now core principle. The first core principle is the client-centered approach. This means shifted from giving advice to working together with the client to set realistic goals. This collaboration increases motivation and long-term commitment. Second principle is behavioral science integration. Health coaches use scientific models like trans-theoretical model and self-determination theory to help a client to identify the barrier and create a sustainable habit. In my country, a trans-theoretical model we are using with the client. This model in 5 stages to assess the patient readiness of change by categorizing in 5 stages. The first stage, pre-contemplation, contemplation, preparation, action, last one, maintenance. The third principle, holistic and preventive focus. Rather than targeting isolated symptom, lifestyles health coaching promote a holistic view of the health. It's supportive preventive care by helping individuals adapt behavioral that reducing the risk of a chronic disease and improve overall quality of the life. Key focusing area of lifestyles health coaching. Now we will go deep to health coaching work in nutrition and physical activity. In nutrition coaching, personalized to culture and medical and personalized performance. And in physical activity guidance, promote regular motivation suited to the individual capacity. Second, sleep and stress management. In sleep routine, we are educate in sleep routine and environmental factor and assess sleep disturbance like to the linked to the lifestyles and stress. And in stress reducing technique, help the client to identify stress struggles and coping mechanism. The last, risk behavioral reducing and emotional well-being. Sustainable use and risk behavioral coping, support to reducing or cessation of smoking and alcohol and other harmful habits. Using motivational interview to explore readiness of change. And also emotional and mental wellness will build self-awareness, self-compassion, and confidence to integrate mental health support into lifestyle prevention. Now let's to see now coaching process in lifestyles health coaching. Now the patient in the health coach clinic are starting to building rapport and assessment by establishing trust. How? We are creating safe and respect the patient, non-judgmental space using active listening and empathy to understanding the client. The second, we are doing an initial assessment to explore current lifestyle habit and health status to see the readiness for change. Identify also the strengths and barriers and personalized value. Then clarify the client vision and help the client articulate meaningful motivational fusion for the health well-being. Second, we are starting to goal setting and planning by selecting a SMART goal, which is specifics, measurable, achievable, relevant, and time-bound goal. Then we are putting actionable planning by break the goal into a measurable step created weekly or daily, align with the client lifestyle. And also anticipating barrier, identify the potential obstacle and develop strategy to overcome them. Last, we will evaluate and sustainability by progress evaluation, assess behavioral and clinical outcome using agreed upon indicate and reflect learning by encourage the client to reflect what worked and what did not and why. Then sustainable change support long-term habit for formation and relapse preventive. Role and competency of the health coach. The role of health coaches started from facilitate of behavioral change by the guide the clients identify the goal and adapt a sustainable health habit and use also motivational technique to support self-directed change. Also work as a supportive partner and health educator. Challenge and consideration in lifestyles health coaching. There is two challenge facing the health coaching, one related of the client and one related the health coaching process. The client related challenge may be because the client there is low of readiness for change. This client may be feel of fear, ambivalence, or lack of motivation, and also inconsistent engagement by missing the session or limited of follow-up, or if there is any complex health condition. Maybe the client have physical or mental health issue, maybe require multidisciplinary support behind health coaching scope. Coaching practical challenge define the scope boundary. The coaches must avoid clinical advice and stay within the ethical non-diagnostic role, and also the measurement impact. Behavioral outcomes are often subjective and difficult to qualify without standardized tools. And also culture and adaptation by coaching strategies must be tailored to this fair background and belief and health literacy level. Let's now to talk about the evidence and research of data speaks. Study indicate that health coaching lead to improve a clinical outcome. For example, like lowering hemoglobin A1C or reducing BP of the patient, blood pressure of the patient, and also enhance patient adherence to treat plan, and also significant improvement in quality of the life of the client, and evidence-based strategy of preventive care. The holistic health model. The holistic health model talk about the whole of the person in physical health, like nutrition, exercise, sleep, and also in the mental and emotional health and stress and mindset motivation, and also include in social well-being, supported system, community. The role of technology in health coaching, like mobile application for tracking process, telehealth and visual coaching session, and also online support communities, and wearing device for activity and sleeping monitoring. Online support communities, we are in Saudi Arabia, we are making in health coach clinic support group. This support group consists of 4 members or more of people that sharing in the same goals, like obesity. All that people have the same goals, want to reducing the weight. There are there in grouping support, sharing experience, lifestyles, habit, and stay motivated of the main purpose goal to preventive, emotional, and supporting and accountability, helping each other. The future of health coaching, increased timing of preventive and personalizing medicine, and gathering integrate with digital health record and driving insight, and recognizing also standarding and commitment of a primary care and key player in building healthier and more preventive society. Conclusion, the lifestyles and health coaching focusing in empowering individuals to make sustainable change in their life, particularly in health, relationship, and career, and coaching utilize strategies such as a goal setting, habit development, accountability to supporting personalized growth and well-being. Thank you for all. Thank you. If there is any question, please ask. Thank you.
Master degree in healthcare management, primary healthcare. 8 years experience in nursing administration and nursing education. I'm proud and delighted to participate in international conference, nursing and women's healthcare in Dubai. My presentation titled Strategies for Managing Diabetes Through Nutrition. Next. Okay, next. Next. So our journey today, understanding diabetes, the facts, what is the team aiming to achieve, what is diabetes lifestyle coach, personalized nutrition, how to eat healthy, and conclusion. Next. So what is diabetes? Diabetes is a chronic disease that occurs either when the pancreas does not produce enough insulin or when the body cannot effectively use the insulin it produces. So as we know, insulin is a hormone that helps to regulate blood sugar by allowing glucose to enter to body cells. Next. Next. Here we have some facts. In 2022, 14% of adults had diabetes, doubled the rate from 1990. Diabetes caused 1.6 million deaths in 2021, which means that's a huge number. And many people with diabetes, especially over age 30, are not taking medication. Deaths from diabetes are increasing over time. Next. What is the team aiming to achieve? The main goal is to keep blood sugar levels within a healthy range. This helps prevent complication and support overall well-being. Next. How to manage diabetes? This can be achieved by balancing macronutrients, eat a right mix of carbohydrate, protein, and fats. Managing protein size, watch how much you eat, especially carbohydrates. Choosing nutrient-dense food, big foods rich in vitamin, mineral, and fiber instead of empty calories. Next. A lifestyle change are best way to prevent or delay the onset of type 2 diabetes. Eating will help manage your blood sugar and also improve how to feel about food. It builds a healthier, more positive relationship with food. We will go through diabetes lifestyle coaching. What do we mean by diabetes lifestyle coach? A coach help people with diabetes make healthy change in daily life, like eating better and staying active. Next. Why choose a diabetes lifestyle coach? To manage diabetes, it's not just about taking medicine. It's about making healthy choices every day. Next. Diabetes is increasingly a major health issue worldwide, with 1 in 10 adults living with diabetes in 2021. Next. We will go through self-management and education. Self-management means taking daily actions to control diabetes, like healthy eating, staying active, checking blood sugar, and solving a problem. Next. Water is the secret of life. It's important to remind this. Everyone is reminded to stay hydrated and not forget to drink water. Next. The proposed strategy, dietary counseling, share nutritional elements but differ in goal and method. So a clinician must understand each clearly. Next. Diabetes societies do not support supplement, yet there is use arising despite unclear, safe, and limited evidence. Next. What about vitamin D? Vitamin D is often low in type 2 diabetes due to obesity and inflammation and insulin problems. So we will take into consideration that vitamin D is often low. Next. Education with support work well. Peer program fade over time. Coaching help most when building confidence and case skills. Balanced nutrition. A balanced eating and resistance exercise help control diabetes and prevent fertility, but targeted treatment for diabetes-related muscle low are still limited. Next. We have two important strategies. The first one is about treatment, and the second, health-related lifestyle changes. Next. Choose the diseases is strongly health system, and patient self-management is key, especially following a treatment plan and healthy habit. Next. Action plan. Managing blood sugar levels is vital for overall health, particularly for individuals with diabetes or pre-diabetes. Next. What to remember? Nutrition is core therapy for diabetes management, not just suggestion. Balance the plate with non-starchy vegetables, lean protein, and quality carbs. Manage carbohydrates wisely, focus on type, quantity, and timing. Personalize the plan with the help of a dietitian. Combine healthy eating with physical activity for best results. Next. Hold the power. Managing diabetes through nutrition is a journey of empowerment. It's about making informed choices that fuel the body and protect the health. Thank you very much. Thank you all.
Thank
I'm Dr. Mashael Huwaikem, a PhD holder in clinical nutrition. Actually, I'm assistant professor in King Faisal University in Saudi Arabia. I would like today to introduce you or to present part of my study. It was about the effectiveness of a nutrition awareness among a pregnant woman on their baby's birth weight. Okay, just a minute. So, as a World Health Organization announced that obesity to become a worldwide epidemic, obesity during pregnancy increases the risk of gestational diabetes, hypertensive disorders, complications during the labor, and high birth weight. It also predicting increasing the risk of childhood obesity and lifelong obesity. So some investigations assess the relation between the maternal weight and gestational weight gain and infant birth weight. They demonstrated positive association between overweight and obesity in a woman and excessive gestational weight gain, greater infant's birth weight more than 4,000 grams. However, there were some studies noted that inverse relationship between the gestational weight gain and infant birth weight. They found the underweight and normal woman who excessive gestational weight gain increased the probability of a give birth low infant weight. Furthermore, studies suggested that overweight and obese women before pregnancy increase the probability of having a high birth with infants. Another study suggesting the reason behind overweight obese women giving the birth high weight infants is genetics factor because of the mother inherited obesity related to the gene to her child. Another study examined the association between the gestational weight gain and infant baby compositions. It showed that excessive maternal weight gain related to greater infant's body fat. Indeed, some evidence showed that the direct relationship between the maternal body weight and infant fat mass. Overweight and obese women before pregnancy increased the risk of high infant fat mass. One more evidence showed association between the gestational weight gain and infant fat mass. So excessive gestational weight gain increases the infant fat mass. Nevertheless, there were 2 studies denying the relation between the gestational weight gain and the infant birth weight. Therefore, we come up for this study by this aim to investigate the effect of the SMS intervention among Hawaiian population on infants' birth weight. Why did we choose Hawaii? Because this study is granted by the WIC organization, and it was conducted in WIC, the branch in Hawaii, USA. So the study population was a randomized clinical trial, was conducted among women participating in a special supplemental nutrition program, Woman, Infant, Child, which is WIC organization in Hawaii. 200 overweight, obese, pregnant women were recruited in the study based on the eligible criteria. There were over 18 years old and gestational age 15 to 20 weeks. First trimester, BMI 25 to 45 kg per meter square, and cell-phone ownership with the capacity to receive 1 to 2 messages weekly. So in the intervention, actually, there were only 83 enrolled. 42 women who were enrolled with the intervention group received weekly SMS for 4 months. For appropriate energy intake and physical activity that met the Institute Medicine of Michigan guidelines for healthy weight gain during pregnancy, and 41 control groups received SMS about general health issues during pregnancy. All the messages were designed based on the social cognitive theory. All the messages were 160 characters or less. Also, women were asked to complete the short questions sent by SMS about the practically of the messages. At the end of the trial, the participant completed the quantitative and qualitative questions about the SMS in the WIC clinic. Participants were given $20 gift card after the first visit and $30 gift card also after the second. So for the total were $50 as a reward gift. So the results showing the majority of the participants were 25 to 30 years old and white in both groups. More than 50% of both groups had a bachelor degree, however, they were not employed. In summary, the participants in the both group were similar, were not significantly different in baseline and age, race, education level, and employment status. Therefore, they are eligible to be compared between those 2 groups. So as we can see here in this chart that there were no significant difference between the birth weight of the babies that were born for those women. So mostly their average birth weight 3,431 gram. For the control group, 3,232. For the here, as we can see, no also significant differences between the both 2 groups. So the babies in the control group for the low birth weight, babies in the control group were more likely to born with the low birth weight compared with the intervention group, but the number is not strong enough to say this difference is real or significant. For the high birth weight, babies in control group were less likely to born with the high birth weight compared with the intervention. Again, there is no difference, not clear, significant, because the result could still be due to the chance. This is mostly that we had in this intervention or in this paper. that already published in 2020. So no significant effect on the infant birth weight and high birth weight were found between the intervention and control group. More intensive educational intervention starting earlier in pregnancy or before pregnancy with a greater sample size may be needed to observe the impact of the birth weight. Those were my references, and this is my contact. And thank you for listening, appreciating your time. Thank you.
Thank you so much, Dr. Mashael, for your excellent presentation.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Narjes Ali Shawarib. I am from Saudi Arabia. Ladies and gentlemen, esteemed guests, it is an honor to be here at the International Conference on Nursing 2025. I extend my deepest appreciation to the organizers for this invaluable opportunity. I look forward to exchanging knowledge and collaborating with industry experts together. Let's inspire progress in healthcare. Today, I will talk about my topic, how managerial support, resilience, and collaboration transform healthcare outcome. When we talk about healthcare outcomes, we often think of clinical procedures, medications, and diagnosis. But beneath these visible layers lies a powerful network of human dynamic, leadership, emotional strength, and teamwork. Imagine a nurse on her 10th consecutive shift juggling patient needs, documentation, and emotional strength. These are not just clinical challenges, they are psychological and organizational. Non-clinical factors act as the infrastructure of care delivery. They influence staff morale and retention, patient safety and satisfaction, team confusing and trust. Managerial support is more than assigning shifts or approving budgets. Let's break it down. Leadership, clear vision, ethical decision, and presence. The resources should be fair, staffing, access to tool, time to care, emotional safety, recognition, opening, and psychological trust. People doesn't leave job, they leave managers. Supportive leadership doesn't just make staff feel good, it changes outcome. And healthcare leadership is not about hierarchy, it's about presence. Allocating resource is not just about budget and separate sheets. It's about making sure every nurse has the tool they need. Every doctor has enough time with patient, and every team has the space to breathe. The key of area to consider: staffing ratio, access to equipment, and practiced time for break and documentation. Healthcare is emotionally intense. From witness trauma to managing grief, professionally carry a weight that's rarely acknowledged. Support starts early. In nursing school, students face academic pressure, clinical uncertainty, and emotional stress. Faculty who mentor, encourage, and guide students build not just competence but confidence. In a clinical setting, the presence of a strong managerial support can be the difference between does chaos and coordinating. Hospitals that invest in leadership development and staff engagement reports great staff retention. It's not just about policies, it's about the procedure. Resilience is the ability to adapt, recover, and grow in the face of delivery. Resilience professionals doesn't just survive, they lead. They are the ones who stay calm in emergencies and support their peers and maintains compassion even under pressure. And there are benefits of resilience, lower emotional exhaustion, and strong peer relationship. And here there are many factors that build or break resilience. About the break, it's chronic overload, toxic culture, and there is many factors also build resilience like peer support and camaraderie and opportunities for reflection and growth. Resilience is not just mindset, it is a muscle. And like any muscle, it's a growth through practice, reflection, and support. Resilience doesn't begin after graduate. It is a start in the classroom. Nursing students face intense pressure, clinical placement, academic expectation, and emotional exposure. Collaboration in healthcare means more than working side by side. It is about shared goal, mutual respect, and open communication between professionals from different disciplinary, nurse, doctor, pharmacist, therapist, and more. When collaboration is strong, can become seamless, patient doesn't fall through cracks. Despite is its benefits, collaboration is not always easy. Healthcare teams often face hierarchical structure, role confusion, time constraints, and lack of shared goal. Or we will talk about the lack of shared the goal across the departments. Collaboration doesn't happen by accident. It's built through the trust, training, and shared purpose. At Mindside Hospital in the UK, a new model of team-based care was introduced. Let's connect The dots, managerial support, resilience, and collaboration. It's not just theory, it is a system that works. When these forces align, the results are transformative. Patients receive safer, more compassionate care, and staff feel engaged, and institutions become more efficient and trust. The recommendation turning insight into action for healthcare leader: be present, listen actively, lead with empathy. For education, treat emotion intelligence as core, not optional. And for institution, measure what matters: staff well-being, team dynamic, psychological. Healthcare is not just about procedure, it's about people, and people need more than protocols. They need support, strength, and connection. Thank you for your attention.
For Dr. Pablo Espada, who has enabled to attend. I would like to thank the organizers of the 3rd International Conference on Nursing and Women's Healthcare and Argentinian Federation of Cardiology. Next, please. The purpose of this survey was to identify and analyze cardiovascular risk factor among nursing staff working in different hospitals and clinics of Morón City by collecting data on age, gender, work condition, health habit, and medical history. The survey I made you assess the prevalence of key risk factors such as hypertension, obesity, stress, and unhealthy lifestyle habits. Understand nurses' awareness of their own health status and readiness to adopt healthier behavior. Provide insight to guide workplace wellness initiatives, preventive care strategies, and collaborative efforts between nurses and doctors to improve the overall health and well-being of healthcare professionals. This information serves a foundation for developing target intervention for fostering a culture of health with the healthcare. The next, please. The next, please. Next picture. Yes. The previous picture, please. Age distribution, the demographic age distribution. Demographic age distribution. So these are the demographic and age distribution data. Most then are really very young. Less than 10% are over 50 years. Next, please. The next, please. Garder. In general, they are women. Family, 19%. The red color is 19% are family. Next, please. Work condition, daily working hours. Almost half of them need to work more than one shift to make ends meet. Next, please. Working condition, multiple jobs. 59% of them have at least 2 jobs. The next, please. Workplace. Most nurses prefer working in the private sector because of higher salary. 54%. The next, please. Monthly income satisfaction. 92, the red color, no satisfied. In my country, nurses are very bad paid with pretty low salary. So it seemed obvious that they were about the respondents. The next, please. Please. The next, please. Monthly migration and willingness to work abroad. Paradoxically, most of them were not in their mood to emigrate. The blue color, 69%. They responded no. The next, please. The next, please. The next, please. Health awareness, high cholesterol, LDL, more 130 milligrams over deciliter, or on treatment. The red color, 56%. Despite working in healthcare facility, they not take care much about one on the most prevalent cardiovascular risk factor like cholesterol. The next, please. The next, please. The next, please, show the healthy diet. Next, please. The healthy diet, a great number admit not being adherent to the healthy diet, in part because they work many hours and don't have enough time to cook. Almost 60%. They responded yes. The next, please. The next, please, shows hypertension awareness. Do you know if you are hypertensive? They responded yes, 65%. As seen in many surveys across the globe, 1 in 3 hypertensive subjects are unaware of their condition. This is a major health care problem. The next, please. Blood pressure control. If hypertension under 130. Only 43% of them refer that their blood pressure reading were normal. The next, please. Body mass index, BMI. Only overweight and obesity together comprise more than 60 of cases. A small number didn't know how to calculate body mass index. The next, please. Sleep apnea. Only 18 of their listeners having sleep apnea. They respond, the red color, 15%. The next, please. Diabetes. Apologize for the slide. The 13th rate of diabetes is considered in global trend. They respond now 76%. The next, please. Smoking status. Most nurses acknowledge tobacco use, so this habit is very prevalent in the population. The next, please. Physical activity, regular physical activity, more 30 minutes, 3 times a week. They responded yes, 61%. 61% of them practice sport or same kind of moderate physical activity. The next, please. Stress. Are you feeling stressed out? Are you, as you can see in this slide, nursing is very stressful profession. The blue color, 92% are stressed. The next, please. Sleep duration. Sleep deprivation is a significant concern among your nursing staff, with many getting inadequate rest. They are falling short of recommended hours. The next, please. Family history of heart attack or stroke. They respond yes, 56%. More than half admit to have those family member who has suffered a heart attack or a stroke. The next, please. The next, please. Hospitalization for heart problems. 93.5% were free of any major advanced cardiovascular events. The next, please. Frequency of medical checkups. Less than half of the surveyed nursery and undergo medical checkups last 1 year. Last year, in 12 months, 32%. The next, please. Willingness to change habits, ready to change daily habits for better quality of life. The blue color, 99%. The next, please. Conclusion. Closing remarks. The survey highlights significant cardiovascular risk factor among nursing staff in Morón, including high rates of hypertension, overweight, obesity, stress, and long working hours. While most participants are aware of their health status and are willing to make lifestyle change, there are areas needing improvement, such as regular medical checkups, better control of blood pressure, and healthier habits. They feeling underscore the importance of workplace wellness programs, health education, and support for nursing staff to reduce risk factors and improve overall well-being. By addressing these challenges, we can help ensure a healthier, more resilient workforce ultimately benefiting both healthcare professionals and the parts they serve. The next, please. Recommendation. Promote interdisciplinary collaborations, encourage ongoing dialogue and teamwork between nurse, doctor, and administration to design effective wellness programs. Implement workplace wellness initiatives. Develop targeted interventions such as stress reduction workshops, healthy eating campaigns, and physical activity challenges. Facilitate access to preventive care, ensure regular medical checkups and screenings are easily accessible for all healthcare staff. Support education and training. Provide continuous education on cardiovascular risk factor and healthy lifestyle choices. Call to action. Let us come together to fostering a culture of health and well-being with our healthcare team. By taking concrete steps, we can reduce risk factors and enhance the quality of life for your college and in college. Support education and training, provide continuous education and cardiovascular risk factor and healthy life choices. And ultimately, improve patient care. The next, please. The next. Thank you very much.
Thank you so much, Dr. Daniel. It was an excellent presentation.
O carro que não é dito. Every day, inside hospitals and health units, there is a cry that goes unheard. It is the silence of women who suffer violence and the nurses who learn to listen to what is not said. Next, please.
Maria chegou ao posto de saúde com o braço machucado. Disse que caiu, mas quem a atendeu percebeu algo além. O olhar vazio, a voz trêmula, o medo. Aquela enfermeira viu não só um ferimento, viu pedido de socorro.
Maria arrived at the clinic with a brushed arm. She said she had fallen, but the nurse noticed something beyond. The empty eyes, the trembling voice, the fear. The nurse did not just see an injury, she saw a silent cry for help. Next, please.
A violência doméstica não é um problema individual. É uma pandemia silenciosa. 1 a cada 3 mulheres no mundo já foi vítima de violência física ou sexual. A dor não deixa marcas só no corpo, mas também na mente e na esperança.
Domestic violence is not an individual problem, it's a silent pandemic. 1 of 3 women worldwide has experienced physical or sexual violence. The pain leaves marks not on the body, but also on the mind and hope. Next, please.
Analisar a atuação da enfermagem e da equipe multidisciplinar no cuidado à mulher em situação de violência doméstica por meio de uma revisão integrativa.
To analyze the whole of nursing and the multidisciplinary team care for women in situations of domestic violence through a systematic review. Next, please.
Compreender o papel da enfermagem na identificação e encaminhamento de casos, descrever as funções da psicologia, serviço social, direito, medicina, destacar a importância da articulação interdisciplinar, identificar estratégias para o enfrentamento da violência.
Here we have the specific objectives. The first one, to understand the whole of nursing in identifying and referring cases. 2, to describe the functions of psychology, social work, law, and medicine. 3, to highlight the importance of the interdisciplinary collaboration. 4, to identify strategies for addressing violence. Next, please.
O papel da enfermagem. A enfermagem é o primeiro elo da proteção. É quem ouve, percebe e acolhe primeiro. O estudo mostrou que seu papel vai além do cuidado clínico, envolve escuta ativa, registro dos sinais e articulação com a rede de apoio, mas ainda enfrenta desafios, falta de capacitação, subnotificação e o silêncio institucional.
Next. Nursing is the first link in the chain of protection. Nurses are the first to listen, to notice, and to welcome. The study showed that their role goes beyond clinical care. It involves active listening, record of signs, and coordination with support networks. Yet, challenges remain: lack of training, underreporting, and institutional silence. Next, please.
Nenhum profissional salva sozinho. A psicologia reconstrói a autoestima. O serviço social garante direitos. O direito protege juridicamente. A medicina documenta e dá provas legais. Juntos formam a corrente humana que transforma cuidado em proteção.
No professional saves alone. Psychology provides self-esteem, social work ensures right, law provides legal professional, medicine documents and provides legal evidence. Together, they form the human chain that turns care into protection. Next, please.
O silêncio dentro do sistema. O silêncio também vive nas instituições. Muitos profissionais querem ajudar, mas não sabem como. A falta de capacitação, protocolos claros, mantém a violência invisível.
Next, please. Next, please. Next, please. Silence also lies within institutions. Many professionals want to help but don't know how. The lack of training and clear protocols keeps violence invisible. Next, please.
A chave da transformação. A mudança começa na formação. Precisamos ensinar nossos profissionais a reconhecer o medo por trás do sorriso e transformar a empatia em ação. Educação permanente e protocolos padronizados são o alicerce do cuidado que protege.
Education, the key of transformation. Change begins with education. We must teach our professionals to recognize fear behind a smile and turn empathy into action. Continuous education and standardized protocols are the foundation of protective care. Next, please.
Do conhecimento à ação. A verdadeira transformação começa quando o conhecimento se torna ação. Não precisamos de novos heróis, precisamos de profissionais preparados. Profissionais que saibam reconhecer os sinais, ouvir sem julgar e agir com coragem. Educação e colaboração interdisciplinar são a base de um sistema de saúde que protege, não apenas trata.
From knowledge to action. True transformation begins when knowledge becomes action. We don't need new heroes. We need prepared professionals. Professionals who can recognize the signs, listen without judgment, and act with courage. Education and interdisciplinary collaboration are the foundation of a health system that protects, not just treats. Next, please.
A esperança e humanidade. Cada ato de escuta é um ato de coragem. Quando uma enfermeira diz, eu acredito em você, ela não só apenas está cuidando de uma mulher, está curando uma geração de silêncios.
Next, please. Hope and humanity. Every act of listening is an act of courage. When a nurse says, I believe you, she's not only caring for one woman, she's healing generations of silence. Next, please. Next, please.
From Brazil to Dubai, the message in this same violence against women is not a private matter, is a public health emergency. Let us turn empathy to protocol, science into action, and care into courage, because every woman deserves not just this service, but to be heard.
From Brazil to Dubai, the message is the same. Violence against women is not a private matter, it's a public health emergency. Let us turn empathy into protocol, science into action, and care into courage, because every woman deserves not just to survive, but to be heard.
We would like to express your sense.
Can you back one slide, please? No, can you come back? One slide, please. More. Yes.
We would like to express your sincere gratitude for the valuable participation in this project. Your dedication, professionalism, and commitment and really essential to the quality and the success of your work. Thank you for contributing in time, expertise, and collaboration. Carlos Alexandre Pereira Staico, Vanusa Maria Albertina, Tarcísio Gonzaga de Lima, Delva Alberto.
There was the collaborations of the project. That's it. Thank you. Thank you.
As referências.
Thank you.
No, thank you. As referências
Next,
no
please.
QR Code.
Next, please. Next. Yes.
Reference.
Good morning, ladies and gentlemen. First, I would like to congratulate the organizing committee for selecting a theme centered on the quality of healthcare. It is an honor to contribute to this dialogue by presenting on the topic of body donation for the training of health professionals in Brazil during this 5th International Conference on Nursing and Women's Healthcare. My name is Bárbara de Lima Lucas, and I am Professor of Human Anatomy at the University of Brasília. This presentation addresses a critical issue for the future of healthcare education. The Spears report titled Gap Analysis and Perspective on Body Donation Programs in Brazil was published in the Journal of Brazilian Medical Education in 2023. And today I present my group, my colleagues Glenda Ferreira dos Santos, who is in charge of the body donation program of Federal University of Jataí, and Professor Andrea Oxley da Rocha, who is in charge of the body donation program of the Federal University of Health Science of Porto Alegre. And we will expand on that work by presenting updated findings and proposing new solutions. So, in this slide, we show two different types of important donation. Each one has its respective federal law in Brazil. If you scan the QR code, you'll be directed to the respective law in Portuguese. One organ donor can save around 8 lives through vital organs and improve the quality of life of others patients through tissue and cornea donations. Although it's difficult to quantify the impact of one donated body, it is known that the donation will enable the training of dozens of healthcare professionals. Each of these professionals will be better able to treat more than hundreds of patients during their career. And in this way, the donation has a beneficial impact on the quality of healthcare for the next generations. The quality of health education, particularly nursing and medical training, relies heavily on anatomical knowledge derived from real human specimens. The International Federation of Association of Anatomists, IFAA, strongly recommends the use of voluntary body donation programs over the historical reliance on unclaimed bodies, since they haven't chosen to be at the dissection lab. Thus, this presentation is structured around 5 key objectives: to align Brazilian practice with international ethical standards, to collect data on existing BDP across the country, to identify the main limiting factors to their effectiveness, to propose evidence-based strategies for public awareness, and to demonstrate the role of community partnerships in strengthening these programs. Historically, Brazil has faced significant challenges in regulating anatomical material for educational purposes. For decades, institutions operated under Law No. 8501 of 1992, which authorized the use of unclaimed bodies. This legal framework, while functional, was reactive and insufficiently structured. As you can see here, we present a summary of various state and municipal ordinances and provisions that attempted to regulate the process in the absence of a cohesive national policy. This fragmented legal landscape resulted in inconsistent practices and limited institutional accountability. Two factors have led to a critical shortage of anatomical material. First, improvements in civil identification service have significantly reduced the number of unclaimed bodies, which is very good. The deceased are easily identified and returned to their family to make their farewells or claimed by them. Second, the number of medical schools in Brazil has increased by over 200% in the past 2 decades, creating a sharp rise in demand. Culturally, Brazil maintains strong traditions around burial, particularly among its predominantly Christian population. Burial is often more affordable than cremation and is deeply present in social norms which may discourage body donation. Although Law Number 10406 of 2002 allows individuals to donate their bodies during their lifetime, this legal right remains largely unknown to the public. This disconnection between legal possibility and public awareness constitutes a major gap in the system. And regarding the awareness gap, strategic partnerships have proven effective. One example is the body donation program Presentes Anatômicos, the first to register donors in the state of Goiás. Since 2020, it has facilitated donations to the Federal University of Jataí. In 2022, the program collaborated with TV Câmara and the local School of Management and Legislative Efficiency to produce and disseminate open access audiovisual materials. These materials addressed common doubts and increased transparency. All respondents involved in this initiative consistently identified public misinformation as the primary barrier to donation. The study was conducted through an extension project approved by the Federal University of Jataí and TV Câmara of Jataí City Council. Formal invitations were sent to BDPs across Brazil, resulting in 34 positive responses. Virtual interviews were conducted between March and September 2022 to collect operational data and identify common challenges. The methodology emphasized qualitative insights from program coordinators, legal advisors, and anatomy faculty. As you can see in this map, in 2020, Brazil had 28 active BDPs. These programs were heavily concentrated in the South and Southeast regions, reflecting significant regional disparities in access to anatomical material for health science education. This imbalance limits opportunity for students in some regions and reinforces systemic inequalities in medical training. By 2023, the number of BDPs increased to 39, indicating institutional efforts to transition towards voluntary donation. However, geographical disparities persist, as 17 programs are located in the southeast and 11 in the south region of Brazil. This concentration leaves the north, northeast, and midwest regions with limited access. With over 400 medical schools in Brazil and fewer than 50 body donation programs, the gap between demand and supplies remains critical. And since 2008, the state of Paraná has implemented a centralized coordination system through the State Council for Distribution of Corpses, CEDC. This council is responsible for managing the allocation of anatomical material to more than 40 registered higher education institutions distributed across 21 cities within the state, which is in the south region of Brazil. While direct donation to operating body donation programs remains the preferred model, this centralized system aims to promote equitable access to anatomical resources across a broad and diverse territory. However, significant logistical challenges persist, particularly due to the long distances between donor location and the institutions, as well as high financial costs associated with body transportation. These expenses, which are often not subsidized, can include embalming, specialized transport services, and fuel costs, placing a substantial burden on institutions or families involved. Additionally, the existence of waiting lists further complicates timely distribution, limiting the system's overall efficiency. And another example is the Provida program. In the Federal District, the Public Prosecutor Office is in charge of the Provida program, a municipal level system that registers higher education institutions and distributes donated body through a structured rotation system. The Ordinance Number 1, 2010 provides a clear and effective regulatory framework enabling the release and preparation of bodies within a 24-hour window. This operational efficiency is further supported by a relatively small geographic area of the Federal District, which facilitates logistical coordination among the 8 participating institutions. Unlike larger states such as Paraná in the south region of Brazil, where long distance between cities pose significant challenges, the compact territory of Federal District allows for rapid and cost-effective transportation. Moreover, all necessary legal documentation, including the death certificate, the authorization for body release, is promptly handled by the Public Prosecutor Office, significantly reducing bureaucratic delays. This integrated and streamlined approach not only enhances the functionality of the program, but also serves as a potential model for replication in other regions, seeking to improve the efficiency of their body donation systems. Now, in 2024, the Judicial Oversight Office introduced a major regulatory innovation in the state of Goiás. Provision number 123 of 2024 updated the state code of norms and formally recognized the body donation agreement as a legally binding document. This change effectively removed the need for judicial intervention in the release of bodies when a donation term is signed. As a result, the documentation process has become significantly faster, ensuring that the donor's altruistic intent is fulfilled without delay. So, the implementation of Provision Number 123 of 2024 represents a significant regulatory advancement. In parallel, public education campaigns have played a vital role. One notable example is the campaign led by Goiás State Court of Justice, featuring Dr. Irani Pinheiro, widow of the former boxer Maguila, who authorized the donation of his brain for scientific research. Such high-profile testimonials help to demystify the process and emphasize the scientific and altruistic value of body donation. Despite progress, some persistent challenges still continue to limit the effectiveness of body donation programs in Brazil. First, legal and bureaucratic barriers. Although legal framework exists, their implementation is inconsistent across states. In many cases, families must navigate complex legal procedures, including notarized documentation, death certificates, and formal consent, often within a 24-hour period, and this barrier can discourage donation. Financial costs. The donation process may involve fees not only during registration, but also for transportation of the body to the institution. These expenses are typically paid by the family, which may reduce participation, especially among low-income populations. Third, lack of social incentives. There are no formal or symbolic social incentives for donor or the families. For example, there is no official day to celebrate and thank donors. Waiving notarial fees can contribute to public engagement. Tax incentives, such as federal and state subsidies to cover transportation, can make donation a truly free option for families. And fourth, public awareness deficit. The general population remains largely unaware of the possibility of body donation. So, comprehensive, culturally sensitive, and sustained public education campaigns are needed. In conclusion, the transition toward voluntary body donation is essential for the ethical and effective training of healthcare professionals. Addressing the gaps in regulation, public awareness and logistical process is critical to ensuring that universities have access to the anatomical resources they need. Moreover, honoring the generosity of donors requires a system that is transparent, efficient, and equitable. By reducing bureaucratic obstacles, minimizing financial burdens, and expanding public education, Brazil can build a sustainable and ethical model for body donation. Thank you very much for your attention. I welcome any question you may have, and you may contact me at the email address provided on this final slide.
This article entitled Generational Gap in Nursing Education, a bibliometric analysis from 1968 to 2021, which was published in the entorno of the Universidad Tecnológica de El Salvador. With you, Ms. Paula Palencia. I am from the Universidad Católica de El Salvador, El Salvador. Thank you for your attention. Now I will present the most relevant data from this research on trend in this topic, as it is of current interest in nursing education. The objective of this research was to analyze the evolution and trends of the generation gaps in nursing education from 1968 to 2021 using bibliometric indicators, identify parents and future lines of research. And regarding the methodology, this was a bibliometric, descriptive, and retrospective study using the Scopus database with the descriptor Nursing Educate and Generation, which yielded 653 results processed with bibliometrics R package. The literature review described the evolution of the topic beginning in 1968 with Takahashi, who initiated studies on social change and the role of nursing education. Heller and others also explored the future of nursing education. Randall studied professional bullying. By 2013, educational innovation, digital technologies, and adaptive teaching strategies were already being studied. Chart 1 shows annual scientific production and production indicator. Here, scientific progress is observed with little activity until 2000, followed by growth peaking in 2020. During the COVID-19 pandemic, a situation that brought rapid social change and the digital explosion of this area. This sheet presents the leader journal in scientific production and first fall shows News Education Today with 52 articles, published articles, and an impact factor of 3.4442 is a significant indicator. The Journal of Professional Nursing also appears with an impact factor of 2.0, and Journal of Nursing Education with 37 articles published with impact factor 1.726. Chart 2, how the geographic distribution of scientific production, showing that the United States lead with 62.8% of published articles, followed by Canada and Australia. Among the most influential authors are Randall with 202, citation for her studies on the socialization of new generation and the transformation of educational practice in nursing, prize with 145 citation for meta studies on early professional socialization and Esquiva with 135 citation for her studies on educational innovation and intergenerational difference in nursing education. This is an important visibility indicator for these authors. This study to identify thematic parents, including nursing education with 285 occurrences in the documents, with keywords such as curriculum and program evaluation, dissemination of innovation, and cultural diversity. Another relevant thematic parents is organization and management with 230 occurrence. This means that the most frequently mentioned keywords is the reviewed documents are related to educational models and leadership, interpersonal communication, and organizational innovation. This indicated that the scientific community has shown greater interest in researching this topic. Another important point is that characteristics of Generation C in nursing have also been underlined, studying the profile of the digital student. Studies from 2019 to 2021 have shown that Generation C values diversity more, is optimistic and pragmatic. Interestingly, they have an attention span only 8 seconds, prefer engaging teaching methods, and reject traditionally assigned readings. This information is important to consider when planning teaching activities. It is important to understand that they are physically present but mentally dissociated. They require respect and dignity from their teacher. And in this population of students, learning improves when they can make decisions, receive instant feedback, and receive ongoing support. Based on the above, the authors recommend strategies such as investing in educational innovation that encourage student engagement, improving peer communication and teamwork, and increasing experiential activities with integrated technology, in addition to maintaining instant and structured feedback. It is also worth remembering that this generation is considered 100% digital and technologically literate. In conclusion, in future lines of research, the main findings mentioned are that the bibliometric analysis revealed exponential growth in scientific production, especially in 2020. With an emphasis on educational innovation, intergenerational relationship, and technological adaptation in nursing education. In addition, some areas of opportunity were detected, such as the fact that there is little research on baby boomer and Generation X. For this reason, it is essential to direct studies towards teaching methods and ways of transferring knowledge in order to propose strategies to close in generation gaps. It is recommended to expand to research by using other databases such as Web of Science and PubMed Central, incorporate qualitative methods that delve deeper into the study of generation gaps and the transculturation of nursing practice. As a reflection, it could be said that the educational community should consider generational diversity as an opportunity to enrich pedagogical practice and foster an inclusive teaching culture that respects the expectations and characteristics of each generation. So far, my report, I take this opportunity to introduce to you Health is CRP, is journal of the Universidad Católica de El Salvador. For scientific contribution or more information, please contact us at this email address. Thank you very much for your attention. And just to let you know, I am here to answer the question you may have about this topic.
Yeah, thank you so much, Dr. Paula, for your excellent presentation. Is there any
Thank you.
questions for Dr. Paula?
Thank you.
Yeah, thank